Well, 76% of patients were already above 150 nanogram per deciliter. And as I said, we had a 0% BCR free rate at 24 months. So super happy to see that. For 76% of patients, as I said, at 12 months were greater than 100, at 12 months following treatment completion. So at the 24-month period, they were already over 150 nanogram per deciliter. And so this was extremely encouraging. We had 95% of patients that at 12 months that were greater than 50 nanogram per deciliter, and at 6 months we had almost 50% of patients. So it's important to recognize once that testosterone level gets back up into the normal range, and having a virtually zero BCR is suggesting, giving us proof of concept that intensification may ultimately have greater long-term benefit and outcome for patients who historically, despite our best efforts at prostate removal or radiation, still have high BCR failure rates. The number of grade 4 events were minuscule, and the grade 3s were actually relatively low as well. And there were no new adverse events that we reported that had not been reported for what you would expect to see in combination androgen deprivation therapy and apalutamide, whether that was in the Spartan trial that led to its approval in NMCRPC, or in the Titan trial that led to its approval in MHSPC. In fact, we saw less rash grade 3, 4, and even grade 1, 2, because we had a pretty novel and important way of educating the sites. So the percentage of rash, which is well known to be seen in apalutamide, was actually much lower in both low grade, any grade, and grade 3, 4. But there were no other adverse events of significance that were different from what we'd normally seen in combining ADT and apalutamide. I just want to say that, we did this trial with approximately 20 U.S. community urology sites that are dedicated to doing research. And we enrolled it all during COVID, and we literally enrolled it in about 18 months. So it really speaks well, number one, to the interest and the enthusiasm of U.S. community urology in doing quality trials. Number two, we had about a 15% African American or non-white population, which I think was really great because it really answers many of the mandates by the FDA and ASCO and other organizations saying, hey, we've got to do better in our diversity of our populations. So we were very proud about that fact as well. And then we even had a little sub-study of about 12 patients where we were able to demonstrate that apalutamide and the oral GnRH antagonist relugolix did not require any dose reductions or dose interruptions. So we really got a lot, and that study, as well as the rash mitigation, have been previously presented and are separately published. This totality of this study has been submitted for publication, and I'm hoping we get it published fairly soon. I think the bottom line is that treatment intensification over a 12-month period post-RP with apalutamide and ADT, apalutamide, a well-established, well-known ARPI, it could ultimately become an option for high-risk localized prostate cancer patients. We need more studies. This was a very important first proof of concept. We clearly met our endpoints, both primary and secondary. And as I mentioned in the beginning of our interview, there are two very important trials, one in radiation, the Atlas trial, high-risk localized patients, radiation ADT APA versus ADT monotherapy for 2 years, as well as the Proteus trial, prostatectomy patients undergoing who have high-risk localized, 6 months of neoadjuvant APA ADT, 6 months of APA ADT adjuvant. So we realize that despite our best efforts in primary radiation, or particularly with ADT and radical prostatectomy, which we don't have any level 1 evidence for neoadjuvant adjuvant strategies, that this may be a way to make these interventions more efficacious. I think Jason Haffron did a fabulous job in presenting at the AUA at the plenary session. Super proud of him and all the great work that he's doing at his institution and all the great education that he continues to do on behalf of both U.S. and global urology.